Hey, my medical coding family, how's everybody doing? Happy Sunday. We already got 15 of you guys on. Thank you for the 4 likes, the thumbs up before you even got in here. I guess I should have gotten some hot tea. Oh my goodness. It'll take just a minute, but my voice will warm up in just a second. Let me go see if I can get some tea. All right. Happy Sunday, happy Sunday. How's everybody doing? Good to see you guys. Happy Sunday, Gloria. Hey, Janelle. Oh. You're ready to take your exam, you think? I had some of you guys know I purchased the licensing for AAPC's course, and I had 5 students do the course with me, and we just finished our 12 weeks of lessons. It was supposed to be only 12 lessons, but we ended up doing 50 Zooms. It was a lot, but it was really cool. My first student took their first one yesterday, so we're still waiting on results. I had it done at a testing center, so sometimes those things don't transmit right away, and sometimes you have to wait till, I guess, Monday or whatever for it to get transmitted correctly. I don't think I'll purchase the licensing fee anymore. I just wanted to see if there was anything in there that was helpful for you guys, because, you know, I like to teach for free, except for the workshops, of course, but I appreciate you guys' support with these workshops for sure. It helps out. Hey guys. All right, we got 23 on. We still got a couple of more minutes. I just wanted to show you just a couple of things before we got started on the practice exam questions. Everybody can hear and see me right, hopefully. Hey, Gloria. Brittany's retaking hers on the 24th. So scared to take it again. Oh, use that first attempt as like an educational thing, you know, like use it as, you know, a really good way to see what is on the exam, and use it as an educational tool for sure. what will be, will be. You're taking it on Tuesday, 3rd attempt. Yes, good. It's been a while. Hey, Cynthia, it has. Hey, girl. It's good to see you guys. So, if you haven't done so yet, I always tell you guys this on the, when I do a workshop and we do mock exams. If you haven't done so, be sure to go to this website on AAPC's website. It comes with this video, and each one of these little lines of text is another video. They go into great detail and show you exactly what to expect if you're going to take it from home, how to present your driver's license, where to put the camera, how to shake out your books, what it will look like on your end when you shake out the books. And then they go through the testing center too and what to expect. So every tiny little step that you need to know about, they'll have it done. And just a reminder, you don't need to spend a lot of money or like buy a fancy desk or anything like that. You can literally do your CPC exam as long as you have an external webcam, right? You can't do it with your laptop camera, but as long as you have, prefer a 6-foot long cable on the end of your external webcam. You can get those for like $20 on Amazon. You can put this and do your exam on anything you got laying around the house. You just need a closed room. You need to cover up any TVs or windows, and be able to show your room that you're secure and you're all by yourself in this one little room, and you'll be ready to take the exam. You don't need a fancy setup if you don't have it yet. You know, get a job first, and then we can worry about fancy stuff later. Some other things is that this exam is not really an ideal situation to prove that you guys are really good medical coders, right? You just need to prove that you are a really good exam taker. So you are only responsible for figuring out which answer is correct, right? So my strategy is always to go the answers first. And what I want you to think about is, if answer A is correct, what will I find in the exam question to make answer A correct? Is it how many? Is it a body part? Is it a route into the body? Those are the key things that are most important on this exam. Is go look at your different answers. Think about if A is correct or B is correct. What's the difference here? Is it how many visits we're billing, or one's distal, one's antegrade, one's retrograde? What is your differences here? And what does that make in the question that you will find if that is correct? That's all you need to do. Be sure you are practicing today by being nonverbal. I will be talking, of course, during the exam questions, letting you know what I'm thinking in my head and how I'm going about looking for the different answers. Some of the questions today are going to be kind of advanced, and I apologize about that. They're not going to be the bare basics, some of them. So it's good that we've got some people that have in here that are retaking it multiple times, but don't think that the entire exam is going to be like today's. You're going to have 2 questions that are easy in each section. So like if you've got integumentary, musculoskeletal, cardiovascular, you know, all the way down, we have 6 questions each. They do have all their questions divided up into pools. 2 questions will be pulled from the easy batch. 2 questions will be pulled from their moderate batch. And then 2 questions will be pulled from their difficult batch. So there's 3 categories in your 6 questions, and knowing that, hopefully that will make it a little easier for you. Don't stress too much. All of them won't be like today's, but some of them are going to be kind of challenging, but that's okay. If you can do today's exam questions and get the correct answer, about 90% of them correct, then you know you're ready for your exam. So be sure and have out your CPT, your ICD-10 book, and your hit picks. And as soon as you see the question, don't worry about me and what I'm doing. Go run in your books and go see if you can't figure out what the answer is. And then in about 2 minutes time, I'll start telling you, okay, where did I go? Where did I go find the answer, and how would I attack these? I do have like little strategies in my head. How do I do E&M codes? How do I do integumentary? How do I do medicine section? So there's different patterns in those codes in each section, and I'm planning ahead every time I start seeing a set of answers from different sections, right? I've got little patterns in my head of how those codes are normally coded. Do we times a bunch of those? Do we never times a bunch of those? Do we add modifiers to those? Most of the exam is testing you on the books, right? Because they can't test you on what can be coded with certain things, but they need to be able to test you on how codes are coded based off the way the book writes them in the book, right? What is in the front of the book about the instructions of how to use this book, and when they describe the different codes, like what are add-on codes, what are modifiers, here's some examples of them. How does place of service affect the codes? How does time affect the codes? This is the stuff that they test you on. So each section will have its own set of rules, like anesthesia has its own set, like, you know, you can't code anesthesia for everything that the patient is having done. We put anesthesia on the most complex procedure. So like if they're having a car wreck and we go explore their liver laceration, but they also have a leg fracture that was minor, but we put them under anesthesia for both procedures at the same time. Which one do you bill for? Probably that open laceration of the liver, right? Because we have to open up the body. When the fracture, we just pop the bone back into place and then cast it. So each section will have its own rules. Some things that I could not find questions in time before I got the set for today done that I know that will probably be on the exam, that I want to make sure that you guys know about and study about before your exam. I've got one here, and I used to mention it all the time, and then I kind of fell off mentioning it. But in E&M section, we have a table here on page, if you're in the 2025 book, page 59. No, you haven't missed nothing yet. I haven't even started with the questions yet. I'm always late, of course. We're on page 59. And this is a table for reporting principal care management and care management services. So the top part is for principal care management, and then the bottom part is for care management services. So are we principal or are we just care? They're divided into 2 different batches here. Clinical staff I have highlighted in blue, or pink if a physician does it. And it's just divided by time. They will say the word principal. If you did just care management, it's also divided up by staff. Did staff do it or did the physician do it? And then it's divided by whether you did chronic care management, complex care management, or again, a principal care management. And I just use this chart. This chart will be important on the certification exam, and I do have it for those people that are, have my notes. It does say at the top, prior exam question area. So be sure to know where this table is. It tells you where the answers are. Most questions that are developed on your certification exam come from any areas in these books that do have tables. If there's a table, they're going to write a question on it. So no matter where you're at in the book, if there is a table, even a tiny table, it will be where they write exam questions. So knowing where tables are in your book is really handy dandy. And the ones that I'm pointing out right here are always utilized on the exam for sure. I just showed off the one for the colonoscopies and the digestive system somewhere. We'll get to that in a little bit too, because I'll be there with those codes. Another area is anytime the CPT book has a coding tip, they're going to write a question about it. This one about the definition of a colonoscopy through a stoma, I think they have it written like 2 times, the same thing, but written differently, but it's still the same exact coding tip. That one, always on the exam. And this table on page 380, it's utilized on the exam, always. And then in anesthesia, here with our qualifying circumstance codes, here with our patients that are younger than 1 year of age or older than 70, and 99140, if you have to rush a patient to an emergency surgery, we add that one on there. Be sure you know where these codes are at, because they're often on the exam. If you haven't done so, be sure to move those modifiers from the HitPix book that are cover anesthesia to this section, because that'll make your exam a lot easier for sure. But let's get to our first question. Oh, don't forget, today, practice nonverbal. Don't mutter to yourself, because you cannot do it. Especially if you're going to take the exam remotely from home, they will stop your exam every time you mutter to yourself. So try to practice not being verbal today. And if you take it at a testing center and they put you in a room by yourself, then great, you can mutter all you want. So that's, but just saying. Okay, first question. Here you go. What are we doing? Why are we medical coders? Yeah, they might ask you this question on the exam. Just type your answer into chat. I'll catch up on chat. See what I missed. You guys email me and let me know how you do on your exam. Rashmi's taking hers on Tuesday, so email me. Let me know how you did on your exam. I'll put it, oh, you can't see chat because I got it covered up today, but you guys know my email address is medicalcodingbyjen@gmail.com. All one word. Yeah, just ask questions, Leanne, in chat. I can see it. You guys might not be able to see much of it because I got the camera in the view. Lizette's taking hers on September 10th. Ooh, coming up. Yeah, if Ben can't hear, then her device she's probably watching us on has the audio Bluetooth to devices like headphones, earbuds, that kind of stuff. Because I'm showing audio going. She probably needs to fast forward the video to catch up. And BEATRIZ, use only Chrome to as browser. You can't use iPhone browser. YouTube is a Google product and it works best with Google browsers. Hey Mary, good to see you. Indeed, we are B. Good job. Anybody know where we would find the definition of national coverage determination? Thank you guys for helping everybody else out in chat. Janelle and all of you guys that have been here for a while and know how this works. Thanks, Go Kart. Yes, make sure your audio is not being sent to Bluetooth devices that you're not connected to, and then also make sure you are using a Google approved web browser like Chrome. It does not work with Apple products. You got to take yours before October 29th. That's my oldest birthday. It will be your 4th attempt, Leanne. Oh gosh, I hope so. Sorella is on her 3rd. No, it's okay. It's all right. We got this. That's right. It only shows screen starting first. F-A-L-I-N-E. You have to fast forward the video. Indeed, hit picks. I don't see anybody with a correct answer for this answer. No, national coverage determination is. So I've been seeing a lot of TikToks, and I'm going to get on my soapbox, I guess, a minute. I did this in our course the other day, but health insurance companies don't determine coverage of CPT codes and ICD-10 codes, right? We have a federal government who enacts laws that write and approve our CPT codes and what constitutes medical necessity for that procedure to be done by a physician, and what diagnoses and procedures go together to determine coverage. And they enact laws in Congress, right? And then those laws are passed and published on the federal government website. And they keep a database of all of our codes, of all of our procedures and diagnoses, and what will cover and what will make payment for each procedure. That is called the National Coverage Determination, and there's a website and a title, you know, like they enact these laws that are called Title V364, whatever. And you can go to the website and you can type in any of the CPT codes, and you can look up to see how nationally they are covered. So, national, would that have anything to do with a beneficiary, right? With B. Right, okay. So, and then to provide payment out to physicians, is that what national coverage determination does now that I've explained it? So, what is our government payer that government would get involved and write coverage determination for? Would it be for all payers or just for Medicare? So now do you guys know what the answer is? My computer flashed, so I don't know if it might want to reboot, but if it does, I'll be right back. Not all payers, not all payers. It just, CMS only dictates its own health plan, which is Medicare. Now, this database that our national coverage for our government insurance plan, that database is used by all insurance plans like Blue Cross Blue Shield and Cigna to give them some sort of standard, right, of what could be covered. So if United Healthcare is denying a particular CPT code, they got their idea of what would be covered or not from the National Coverage Determination. So they can interpret what the government wrote up on those laws themselves and read those words differently. You know, like I can read a name and I interpret it something different than somebody else does, and we're both looking at the same word, right? But it means something different to both of us due to whatever cultural or belief systems or whatever else, you know. So same sort of thing for all of our payers. They do use this national database, but it's not a rule or a regulation that they have to follow, but it is something that they do go off of. So this is our answer. I don't think this is working right. Okay. Because I don't see my OBS moving like it should. Okay. Let me try closing this and then opening it back up. I'll be right back. No, why are you not? There we go. Okay, now I got it moving. Okay. There is our answer. It is C. There's our title. And I won't be able to teach like this too much on some of the rest of the questions like I did on this one, but I know it's something that you guys haven't seen before, and I'm passionate about it. So anyway, there is answer C for this one, and you guys can look back and y'all can go to that website and actually look up this database too, so kind of cool. ABNs. And here's a picture of what one really looks like. What do you guys think is the answer for this one? Yep, because it's the government, yep. I've been trying to find questions that you guys haven't seen before. So that was a really good one. Everybody should know the answer to this one. You always, 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 when you see ABN, look for the answer that says prior, right? And there is a website that you guys can go to if you want more information about ABNs. But always, ABN, prior. Another question on medical necessity, which is the same thing as kind of like national coverage determination. We'll have 7 questions in this type of area, kind of like, you know, guidelines, government stuff, compliance, regulatory, one of our biggest areas. Try not to read the questions because I make it too easy for you guys. What do you think the answer is? Correct. Anytime you see medical necessity, remember to always look for the answer that has least radical. Like in your book, when you make your notes for all your laws and regulations, right? Like I do, you know, what is MIPS? What is ABNs? All that kind of stuff. Be sure to write down least radical near there, okay? Super helpful. And I do have a cool definition of medical necessity there that you guys can look at later. I wonder if anybody can do this one. I know I've not ever presented this one before. Oh. Your guidelines contains instructions how to code to receive diagnostic services. Where do we find that? Anybody know? We've got section 1, which is our conventions. B is general coding guidelines. C is coding diagnosis specific, right? Then we have section 2 is principal diagnosis. Section 3 is reporting additional diagnoses. Yep, right here are section V or section 3. We've got additional diagnoses. Section 4 is diagnostic coding and reporting. Just knowing where this one page is at in the front of your book, the very first page with all the little lines on it that tell you where in the G section things would be, is super handy dandy. And to know that you can find answers here, super handy. Yep. Mary, I'm on the very first page, just the very first page. The one where your official guidelines are right at of your ICD-10 book. It's where, you know, you've got your conventions, all your chapters, and then they tell you what page number inside the guidelines of where things are at. Knowing that there's all these different sections and appendixes and what the titles are to them is handy. Yes, this one is D. So in your book, in your ICD-10 book, if you look at that front page that's got the diagnoses or the guidelines in it right there, being able to know what your headers are and being able to find the header for 4 that talks about your diagnostic services, which is in your K right there, is super handy dandy for sure. All right. NOS and NES, not really S's, but I keep doing that. I'm so dyslexic, but NEC and NOS, I did that on a recent TikTok video. I keep calling it NOS or NES and NOS, but it's NEC and NOS, but same thing, sort of, kind of. This one will definitely be asked on the exam. Do you know how to go find your answer? Like, if we were here and you wanted to find your guideline for this patient, what would we look under? Section 1A, B, which is on G3, which gets us to NEC and NOS. What does this question have in it, and what does it not have in it? It does not tell us if it's bilateral, right or left, so we do not have enough information. If our doctor does not give us any information, I remember the 0 means not enough info. If it's E, right, E means we got a super educated physician in that second spot right there. I always remember that we've got too much information and there's just no code for that. So, yeah. There is a really cool chart here that AAPC drew in, so that if you want to know if your code is going to be NES or NOS, you're supposed to use it. It's figure IA9 on the bottom of G3. And does your provider document have specific details for that condition? Like in this child's, it didn't tell us right or left or bilateral. There was no specific detail for the condition. We just knew the condition, right, otitis media, and it was acute, but we didn't know the specifics. So right here, and it tells us which one to use, right? And if we've got specific, it tells us to go there. So anyway, they're wanting to know if you know how to do that. All right, guys, what about this one? If we're using our alphabetical index and we're going to go to appendicitis here. I'm looking for, in our alphabetical index, which one of these diagnoses has a instructional note. Do I have one at appendicitis? In the alphabetical index. Do I have one at diabetes? At our first diabetes. Do I have one at the word symptoms? I doubt it. But let's go look up It's not really a diagnosis. Do I have one at the fibrosarcoma? Which one has an instructional note in the alphabetical index? That's the only thing that we're supposed to be using to find this answer. What do you guys think? Yeah, the purpose is not really to CC my book, but to use your book and kind of gauge if you're in the right area or not. Use your own books and see if you can't find these 4 different diagnoses in the alphabetical index, and to see if you can find which one has an instructional note. The last answer was NOS, right there. You can always hit rewind on the video too. Alright, this one, yes. Do you see how they have in that alphabetical index in the fibrosarcoma? It says see also in your alphabetical index. We usually have that in the tabular list, so it's kind of neat to see it also in the alphabetical index. Here's your one on hypertension. Once I go somewhere and I find something, I like to highlight that I've been there. Hard to believe I've never highlighted hypertension before. But here in the alphabetical index, what do the terms in parentheses mean? Where would I find that answer? In our guidelines, right? I would look here for punctuation, which is G3, right there. What do parentheses mean? My definition will be right there of what those words mean. There's a whole bunch of them. 1, 2, 3, 4, 5, 6. 6 words. Do they have to be there? Does that mean that we need 2 codes? What does it mean? Girl, because we do not know where the otitis media is, right? It's supposed to say right, left, or bilateral. You have to add your laterality with otitis media because you have 2 ears. So that's why it's NOS. We do not have enough information. You have to code laterality. It's in your guidelines and it is explained here. We do not have enough information. Look at that right there. We do not have enough information. We're supposed to have a 5th digit. See, when you go to the H669, we got to have a 5th digit, which is right 1, left 2, 3 is bilateral. And if we can't do it because we don't have the information, then you have to use an O, like it tells you in your guidelines, guys. Yep. You have to do a bilateral. We do not have specified. We do not have the specifics. There's no specific detail, right, left, or bilateral. So that's why we use the O. They're still working on that one. Okay, hypertension. Did we do this? What was in the parentheses? What is it? acute is not the only thing we do with otitis media, acute or chronic. We got to have laterality. Hey, Carol. Carol, that's probably, and you do have Chrome? Do you have the latest version of Chrome? I have the same trouble when I'm not on a desktop. When I'm on my cell phone, chat disappears or I can't find the drop down for it, and it's so frustrating. I usually have to just back out and go find it again. C is the answer. They're just supplemental words. They could be present. They don't affect the code assignment or anything. They're just there as AKA words. I showed you here where I went in the guidelines, found the punctuation right there, and then I went to punctuation at G3, found the definition there, and then also in the alphabetical list, what words they were talking about visually are right there. So, general coding guidelines for this question. Okay, all back. Here we go. Let me bring back up the Word document. There we go. And we will, Scoochie, where am I at? What have we got? Why are you so big? Alright. There we go. Make it down just a little bit more. There we go. Okay. And we'll scoochie. Alright, so far we did this one with B. National coverage was C. R, ABN, prior, medical necessity, love it, B. We've got our Title 4, yeah, Title 4. Our lovely NOS, because we did not know our laterality. You've got 2 ears, and you need that info from your doctor, or you bill NOS every time. And then we've got our fibro. We found that additional note in our alphabetical index that tells us a fancy thing we needed. Our hypertension. We are working on our supplemental words. And then now we are deciding what we do with a suspected bilateral meningitis. What's our guideline? I was going to general coding guidelines right here to let us know what we needed to do. Before we got rudely uproot. And go IB4 for our signs and symptoms. IB4, G5, probably. So if we have something that is and we've got our, probably our IVD would probably be helpful too. Yep. Codes, signs and symptoms under G35. Let's see if they've got a better explanation over here. G35. Oh yeah. I've got some notes about uncertain diagnosis. Yep. We're going there. C says uncertain diagnosis, suspected, likely to, questionable, possible. Gives us some guidelines on what to use. That's helpful. Our differences between our G03 and G00 be the next thing I'll worry about. G00 is bacterial meningitis. Our G03 is meningitis due to other and unspecified causes. Which one would I use based off those guidelines in the front? I gotta go bring up the YouTube thing because I don't have that up yet, so I can see you guys' chat. Forgot about that. Alright. We got 43 on. Isn't it nice to watch one of these live streams without the advertisements too? That's always nice. Besides my computer rebooting, it's nice not to have the interruptions. Alright. Sound is going in and out. Everybody got C? Stream running better now that we've rebooted. Y'all let me know in chat if it seems to be running better. Alright, are we doing an R code or a Z code first? We have a guideline for that too. That will be in the front. We're going to be going to IV. Patients receiving diagnostic services, IVK. So that's on page 36. Patients receiving diagnostic services. What goes first, an R code or a Z code? What does it tell us? Yeah, in my ICD-10 book. If you have a different version of the ICD-10 book than what you're looking in, then it could be on a different page. It just depends on which book you're looking in. Right now, I happen to have open the 2024 ICD-10 book. It might be different depending on which book you're looking in. You can use any of them. I've got tons of them. But the IK won't be any different, right? No matter which version you have. Sometimes people have Optum or whatever. This is still saying in the 2025 G36. So G36, wherever your guidelines are at. I think Optum and them have them in, like in the back of the book somewhere. But it's still going to be, oops, I'm in 26, not 36. Wherever your guidelines are at. But because they allow us to utilize any books, it could be anywhere else. But right there, patients receiving diagnostic services only. Patients receiving diagnosis services during an encounter or visit sequence first the diagnosis for the condition or the problem or the reason for the encounter or visit shown, and then any other additional diagnoses. In the absence of any signs or symptoms, you can use the Z01 code. I've got lots of little examples down there. Leanne, you got to use your guidelines. You've got to learn how to look up what the scenario is and be able to look it up. So if you're in the ER for reasons like, it varies depending on why you're in the ER, right? You need to be able to go look up. If you're there for underdosing, toxic effects, adverse reactions, they tell you in your guidelines which one to sequence first. 1, 2, 3, 4. You have to be able to go find your tables. So being able to utilize these pages and know where to find the guidelines so you know which page to go look up your sequencing is what you have to learn how to do. You can't memorize every single diagnosis scenario you might see in the ER. That's why I'm utilizing the guidelines today per question, showing you where we're going to look. Some of them are not under section 1, 2, or 3. Some of them are under sections 3, 4, and 5 in your first page of your ICD-10 guidelines. You need to get familiar with looking these guidelines up. If it's only dealing with malignant neoplasms associated with a transplanted organ, where is that guideline? Where would you find it? What if you're only doing a radiology service on a patient? It's here. But we're doing exam questions just like it's exam day, and we don't have time for like teaching. We got to go from one question to another. Where would you go in the book to go find it, right? So right now, we're doing a question on radiology. This patient, Mr. Ronald, got here at a diagnostic center. He's having difficulties swallowing, and he has a father with esophageal cancer. Would we use an R code first or a Z code? And the only way to know that is if you know how to go find section 5 for diagnostic coding and reporting guidelines, and being able to find that patients receiving diagnostic services only is going to be on G36, and then it will tell you there which one goes first. Lots of practice. Lots of practice. You don't have to memorize anything, but when you do a question in this area and you had to go find where K, section 4, level K diagnostic procedure, what comes first, be sure to highlight all your steps. Highlight where you found it, and then where the guideline is, which one goes first when you figure out what the answer is. This one, would we use 1 or 2 diagnosis codes? We would use the family history. Your difference between your Z80 and your Z85 is quickly found. You don't have to look at the 5th or the 4th digit, but if you just run to Z85, the first 3 digits, you'll see that that header is personal history. So I know that family history will be our Z80, right? So then I don't even have to go look up the Z80. Don't verify you have the correct answer when you've already eliminated one of the answers. So we know A is our correct answer. You literally have 120 seconds, and questions have already been started and going, and then you've got to be able to go run and find the next answer. What about MIPS? Which one is not a component of MIPS? MIPS are mentioned in the front of your ICD-10 book too. They are listed in the features of your ICD-10 book, which is page 1 of your ICD-10 book, right after your guidelines, all the G codes, and then they're mentioned again in your symbols and conventions right here. Any diagnosis codes that are all black are not MIPS, but any of them that are pink as far as the number goes, like H35, is a MIPS code. And you know that because of the way the symbols and conventions go. If you have not read the practical steps to coding, including your features of your book and your preface that tell you how this code book is set up, what it has inside of it, including all the symbols, and that's what they're going to test you on. Do you know what a MIPS is? Did you define this? If there's any words here that you don't know what this program is or what kind of code that is, and there's no definition of what it is, go Google it before your exam day. Write down what a MIPS is. What is anything that's here? Any of the age symbols, sex symbols, any of these things or programs. If it's here and you don't know what it means, be sure to go Google it before exam day and then have your definitions written out. Makes it a lot easier. Which one of these does not do MIPS? Anybody know? Correct, Amber. You are at a disadvantage if you're doing an AAPC certification without their book. Only their version of the book has their charts that they add into the manual throughout the entire set of guidelines, which will make you at a disadvantage not having their books. They're testing you to see if you can find things in their books. This dependence, abuse, and use chart is a question on the CPC exam. Not that you can't pass with an Optum book. People do it all the time. But you are at a disadvantage without their books, because this is what they're testing you on. Anything with a chart in it, in the guidelines, they want to know if you know where it's at. Now this chart should be there because this isn't copyrighted by AAPC. This chart, IC19E, adverse effects, should be in Optum's guidelines too, because it's not written by AAPC. They are good. The 2025 books are good till December 31st, 2026. The 2024 version, which I've been using for today's exam, is good till December 31st, 2025. Correct. You have to, Leanne. The code won't tell you which one to go first. Maybe sometimes in the tabular list it'll say code first, but it is always better to find the rule in the guideline. Because what if you go to a code that doesn't have the code first? What if you end up at the code that is just the secondary code and it doesn't say you need to code it first because it's not the first code? You need to get muscle memory down. Everybody got admission rates? That is not one that's on there, so that you can find all of these. Do you know what an AMP model is? CPT book has a instruction for use on their set of book instructions too. Be sure you've gone there too and know. There is more symbols about HCC, which ones are HAC, which ones are AMP. Knowing where to find these different programs is super helpful, or having them written in your book. Correct, Janelle, you are good till December 31st. Yep. You have to Google it ahead of time, Cynthia, before the exam. There is no definition in all three manuals about what a MIPS program is, unfortunately. So you have to have found this practice exam question from AAPC. All these questions came from them, and have done it and figured it out, because it is in their study guide. If you have their study guide, right? I'm always preaching. MIPS will definitely be talked about here in your business of medicine, and so will your AMP in your ICD-10, Introduction to ICD-10, and all that stuff. So we'll have all those different payment methodologies and stuff in your business of medicine. And it's also in their course. If you've ever taken the course and you've got their training manual, it'll also be in their training manual for what MIPS and AMP is in, so, and what they are. There's our APM. Do they have MIPS here too? And there's our MIPS, and then the definitions will be back here in the course. There's your MIPS criteria right here, and then they will ask you a couple of questions like this that will be only available in their course or in their course material, and so that they make it a little bit of your disadvantage if you don't spend the $3,000 to take their course. But this is just, you know, 2 questions that I know you guys probably haven't seen if you haven't taken the course, and I just want to make sure you guys know that there might be something like this that might show up on the exam. And you can Google these. You can find out all about it. You don't need an entire course, but you can absolutely find out about it with Google. Your girlfriend will tell you. But they are terms that are in your ICD-10 book, and you should have looked them up, right? Because why are these codes pink? Why are they black? They tell you in the front that they're part of a program. If you don't know why something is what it is, you need to be very inquisitive, and you need to find out. Go ask, why are there pink codes in the ICD-10 book? What is that part of, right? Anything you see that you don't have a clear understanding of, be sure to Google it. All right, A is correct on this one. This one, which one is not part of AAPM, what I call AMP, is D. It is bundled. Which bones have trochantars? Do you know where you can find that answer? If we go to our muscular skeletal section in our ICD-10 book, AAPC's version, I don't know about anybody else's version, has all the anatomy you could possibly want about the muscular skeletal system. It starts out with the skull all the way down, the structures, all the vertebral column, and then we'll go into each bones, right? So we got all these bones, all these bones, all these joints, all the joints, all the muscles, and then it'll talk about the diseases process, osteoarthritis and all that stuff. So if we go back to our bone section, not our joint and not our muscle section, we ought to be able to find a bone, a set of bones, right? Humerus, tibia, and femur. We need to stop at those and see which ones have trochantars in them. Scapula, pelvis, there's the femur, there's the tibia, and where's humerus? Humerus will be up here in the arm-ish area, right? What do you guys think? Business of medicine. There you go. Thanks, Carol. Indeed, we are C. Yep. And this is only if you're in the 2025 AAPC ICD. All right. Which one is not part of the thoracic? Where are we going to run to find that answer? Don't forget about our illustrated review. Talks about some different body parts and positions, of course, and we've got body parts there. We've also got body parts here that we can think about. far as body parts and regions go, sure. Everybody see this one about which one is not true? Be sure you are thinking about which one is not true, right? Thinking about thoracic, abdominal cavities, inhalation. You could be here in the digestive, but also you could be in respiratory, right? So be thinking about these body parts. Where is your thoracic diaphragm, right? And which one is not part of the thoracic diagram? I told you guys these were going to be super difficult. There you go. Yep. Today. But if you guys know the answers to these, you can pass any question on the exam for sure. But whatever you got and you've seen today, if you make notes in your manual about them, you'll be overly prepared for the exam for sure. Okay, what about this one? Go back to probably our digestive for this one, right? Our digestive system, or you can use what you've got here. Be sure you guys have written, if it has a line to it, I like to write its function down. What is its function in your CPT book? We're looking for splenic. Probably on this page, 752. Indeed, we are C. One more NES and NOS. I know it's something that a lot of people have struggled with. And another question, I'm not quite sure if you guys have seen this one or not. Or if it's just another reversion of something else we've seen, but just typed a little differently. What is NEC and NOS? What do they consider them? Where do we find them here on this page? What are they under? That's all they're asking you. If you needed to find the definition for NEC and NOS, what header are they under? That's what they're asking. Abbreviations. What do the instructions and the conventions tell you? What do the instructions and conventions of the classifications do? I'm sorry, I'm not supposed to be reading these questions. Here I am trying to read them. Not supposed to be reading them. Y'all are supposed to be trying to do them like it's exam day. I already have the answer highlighted on this page for you. Do you know where to go? If you are here at your guidelines and you at least read them through once, that sentence should spark a memory. Right here it says these guidelines are a set of rules that take precedence over guidelines. Right there, that sentence. Shawnee's still behind us a little bit. She needs to fast forward a little bit. Yeah. We are B. For the guidelines. Yep. Ambulatory surgery procedures. How is the diagnosis determined? Would we be under Section 1, Conventions, Section 2, Guidelines, Section 3, Coding Specific? Are we going to be over here in some of these other areas like principal diagnosis, reporting additional diagnoses, diagnoses for outpatient services? That sounds good. Where is ambulatory? In ambulatory, another G36. See where I found that? N is in Nancy, G36. Then we go to G36. You'll find the header N for ambulatory services. Right here is what it tells you. Make sure your question is asking you a true answer or an incorrect answer. A lot of the times their wordy questions are asking you to look for an incorrect answer. So be careful with that. This one's asking for a correct answer, which is okay, but on exam day they may ask you this same ambulatory question, but they may ask you for an incorrect answer. So you find something that is not listed there. Just a couple of more, and then we're going to get into ICD-10 sequencing again, and then we'll be doing CPTs all the way through to E&M. Hang in there. What do you guys think is the answer to this one? Correct, Cynthia. This one is C. Good job. How are you going to find this answer? Are you doing something that is diagnosed in the A section? Bloodborne pathogens. Are you dealing with a symptom? Bloodborne or something in the stomach? What are you doing? I think about the headers of each chapter. That's why not tabbing these and knowing where sections are, like the tummy is K, it's the red there, that's super handy dandy. Blue is your circulatory system, right, for hypertensions. Purple, your ears, your bilaterality that you need to know, and your eyes are the blue. So knowing your color codes is super handy dandy. You use your alphabetical index, you look up gastritis, and you go down to viral, it tells you what the answer is. Which is C. Good job, Lizette. You did a really good job on that one. Val, you too. Good job, go Cart. All right, what do you do for this one? Are we dealing with something in the G's? G, the header is what? Let's forget that one. C, D, E, F, G. That one is our nervous system. Or do we have an injury code, which is our T code? If we have both of them, which one goes first? Those kind of things. You can. If we go to our alphabetical index, we go to section C for chapter specific. You can see that this patient's developed Parkinson's due to medication. So that would be chapter 19. For our adverse effects, which is IC19E, which takes us to G27 here, which is that lovely table you really want to be able to find. Let me get it up here on the camera. because it is so handy, because it tells you the sequencing depending on what it is. If it's an adverse effect, if it's poisoning, if it's underdosing, or a toxic effect, it tells you what to code and in what sequence, right? All in one chart. This should be in everybody's ICD-10 if you can find your guideline for this. Because it's not written by AAPC, it should be in everybody's guidelines wherever they're at. What goes first is the nature of the adverse effect, like tachycardia or delirium, right? So our Parkinson's should go first, and then our T code, injury code, should go second. So we know also if we stop off at our T43, you do not go down to your 7th or 6th character. Just stop at T43 so that you can find the definitions of the 7th character, because you have 2 options in your exam question of A or D. And the faster way to figure it out is if you stop at T43, it gives you the definitions of initial, subsequent, or sequela for A, D, and S, and that we have a new, it says first face-to-face with new PCP, so you know this is initial. It's not a subsequent encounter. It would definitely have to have an A at the end of it. And we know with our guideline that it has to have 2 diagnosis codes, and that the Parkinson's go first, so we know our answer is A. Modifiers are in your HIPICS book. Hey, Lester. Yeah, that's kind of hard, right? Are you doing an adverse reaction, or are you doing a toxic effect? It's like, ugh, that comes with practice. Or is it a poisoning? I mean, you know, it's crazy. If you think too hard on it, you could drive yourself nuts. Just figure out what AAPC wants as the answer. Make notes at your guidelines and at your G code and at your T code. You should add those examples to everything that's involved in that question. That way, if you see it on exam day, you'll remember which one they want. Thank you for the 12 likes on today's live. We still have 36 people on. What do you guys think is the answer for this ambulance modifier question? Nope, I still don't see a correct answer. Did everybody go to their, I don't think, first code in your HIPICS book, which is A0021, and then right above it is your ambulance modifiers. We need to look for the place that they picked the patient up at. Where did they pick the patient up at? At a rehab center. What letter is rehab center, right? Therapeutic suite, right? They're doing therapy on the patient, so that's a D. So our answer must start with a D. So I don't even need to look up anything else. I can pick my answer and move on to my next question. Be sure to open up a book and think about these differences. What would be another AKA word for a different name for a therapeutic service, right? That's a rehabilitation center, right? Because they do rehab, which is therapy. Write those definitions in. Okay. Here's you another one with some signs and symptoms. Where's our guideline for this? IB what? Impending or threatening diagnoses. It says see figure IB11, which is on G5. This is written by AAPC. Not everybody may have it, but IB11, impending or threatening diagnosis. The provider documents an impending condition. Correct. Did the condition occur during that visit? No. Review the sub-entries in the main terms under impending or threatening. Is there an impending or threatening whatever, if that's part of it? Impending menopause. So we need to go to our alphabetical index. We need to look up the word impending. A, B, C, D, E, F, G, H, P, E, N, D. Impending. Impending. Is impending menopause listed here? No, there's only 3 diagnoses that are listed here. Coronary syndrome, delirium, tremens, and then myocardial infarction. Impending menopause is not here, so we cannot code it. So we have to code what? Instead, what did our guideline tell us? Which is just number 11. Even if you don't have this chart, you will find your answer right here at 11. Impending or threatening condition. If it did, if it's not in the alphabetical index, then what do you do? We have upset stomach and insomnia. So that would just be how many diagnoses, codes would you have for that? A only has 2, 1, 3, or 1. If we can't code menopausal, we can only code the symptoms. We have 2, right? So without even looking them up, I only have 1 answer with 2 diagnosed codes. So I would pick A and move on to my next one. finally, y'all are done with guidelines and rules and regulations that I think that you might not know for exam day that might appear, and I just want to make sure you guys have the answers to those that you can write in your book. Let's go and do this integumentary question. Michelle, when you replay this live, I have the page numbers and screenshots of where I have the answers right there for you. And it's just right above the very first HIPIX code in the book. You can pause that later and view that again. But go look at the AAO, whatever the first number is in your HIPIX, and it's a chart right there, right above the very first HIPIX number. You're welcome. Isn't that crazy? There's so much tiny little details in some of these books, and they know that you probably haven't been taught about it, even if you had a course, where that little chart is. You're welcome. Now, why is my CPT book pointed only to this piece of paper? Because this is where I would have found the answer to this question. I would not have gone to the individual codes to look up this answer. I would use the beginning of the chapter, and I would look up my codes from here. Answer A is under this blue header. Answer B is under here, this blue header. Answer C is under that blue header. And then answer A is up here with introduction, right? So these answers are separated by blue headers, which two of them are under induction and removal, one of them's under biopsy, and one of them's under an excision. I would look there at my exam question and see, what did I do today? Did I excise? Did I do a biopsy? What did I do? We incisioned and drained, right? So now my answer has to be A or D, right? Utilizing this thing to compare your answers to, just to see the differences in the surgery types, is a faster strategy instead of running from code to code to code. You can just see what range the available answer is here and see which surgery each code is under and be able to pick, or at least eliminate and get yourself down to where you only have to go to one area to figure out what your answer is, right? Did we do something that was complicated or simple? Easy peasy, right? So don't forget about that right there. That you can actually use this to look at your headers of your surgeries and then only look in your question for what you did, what type of surgery it was. Did you do a biopsy? Did you do an excision? Or did you just do an I&D? You know they'll only be in that code range, and that will make things a lot easier for you instead of flipping around and getting lost and then reading CPT code descriptors and forgetting where you're at, that's a lot better strategy. What do you think about this one? Our 1700s are under destruction. What's our 112 under? 112s are under removal of skin tags. What did we do today? We did skin tags. What did we do to the skin tags? Did we remove them or did we destroy them? We scissored. We just sliced them off, right? So you know you're not going to be under the 1700 area because we didn't vaporize them with something, right? So, where do we put 17 of them? The cool thing about this too, when you use this, it tells you what page number to run to, so you're not looking up and down the columns for your code set. If you use this to figure out which header you're under, it tells you specifically what page to run to. Save you more time. Instead of searching up and down columns for codes, you can run straight to 91 and you know your codes are right there. Save you more time. So if we had 18, what would be your answer? They're wanting to know, by the way they wrote these answers too, do you know what types of codes these are? How do you code them together? Which ones can you use modifiers, which ones you can't? Yep. Perfect. D is our answer. Good job. What about this one? Those might be all under the same header. If they're all under the same header of the 19s, 119, they may not have to look here. We just may have to go to them. 1920s and the 50s. So the 19 or the 119s. Sorry, I'm in the wrong number. 119. 119 introductions right there are under introductions, and then that's A and B, and then C and D are under breast introductions. What introduction is that one under? Just general skin. What are we dealing with today? We are dealing with breast, so you know we have to be under those codes. So we'll only keep C and D. Do you know how to code those codes? Would we add the 50 modifier or not? And also it tells you that what page number they're on, so you can run to them easily instead of having to, run all over the place or try to find those codes. You already know what page number they're on and you can turn right to it. Or are we doing tattooing? Tattooing, where would tattooing be? For not excising the breast, for actually just doing reconstruction, That's a different bear. How do we tattoo? That's pretty cool. That's our different introduction for sure. If it's not the breast implants and all that stuff, then we are back there at our 11s. And then we got to do by the square feet. So if we have more than 6 square feet, how do we code that? And would we use modifiers on these? I thought this was a breast implant after a mastectomy. That's what they usually always are. But it's not. We're just tattooing. We did right and left. All we're introducing into the breast is ink, right? So our 19350, where is that? 19350 is nipple reconstruction. We didn't do that today. I know it says reconstruction in there, but what did we actually do? Patient presents for tattooing of the nipple and breast. Okay, we did go under the reconstruction. Perfect. So we're going to have the reconstruction . Or 11921. What does it say we're doing there? Tattooing intradermal introduction of opaque pigment to correct defect micropigmentation. The total area was that. She had reconstruction done on a previous surgery, right? We're just doing her tattooing because she's already had her reconstruction surgery. We didn't do reconstruction today. That would say that they used a scalpel, they incised, they used Vicryl to close the wound. They didn't do any of that. They just were, oh, by the way, she had breast reconstruction previously, previous surgery. That's why we're doing tattooing today. That's all. But we didn't do that. The total area in square feet would only be documented that way if the only thing that you did today was just tattoo her some nipples on, right? So what do you guys now think the answer is? Carl, look at the way the descriptors are written. So if we go back to 119, where are we at? Right here. Our 11920 is for 6 square feet or less, so we did not do that code, right? if we go over here to the 2-1, did we do up to 20 square feet? Yeah, we did 11, right? So we know we can do the 21. 11 goes right in between here. Now, we did on the right breast, we did 11. What if we did an additional breast for another 10? What do we use? We use the add-on code for each additional. If you add those two together too, you're going to get 22 altogether. So if you did 20 here and you needed to add on for your 2 centimeters over, right? What are we going to add? So now what is your answer? There you go, Brittany, Trey, Cirilla, yes. Lizette, yes. Faylene, yes, yes. Now you got it. Yep. First, see if you got up to 20. And if you went over 20, then you go here. If you're less than 6.1, then it's just the one code on the other side. The one code on the other side will never have that add-on code. That add-on code only goes to 21. That's it. This is a question that everybody gets wrong on the exam, and I saw everybody struggling with it today too. So, yep. I'm glad I went over it. Okay. What's your differences between those codes? Indeed, just manipulation, that's all. And they might not use that word on exam day. They might say reduction or something a little different. It's kind of like the same word, so should be careful about that. Oldie but goodie, but another question in this area that is always on the exam, but sometimes asked differently. Every time I see this question, it's asked differently. Reconstruction in the past tense. A, yes. Remember, if you did it today, it would say scalpel and, incisions and manipulating tissue and all that stuff. So yeah, isn't that crazy? This one again can be answered in your ICD-10 book. under the M codes, right at the beginning, where they talk about what is a bone, what is a tendon, what is a ligament, what's a artery. You know, they have all that stuff listed there. There you go, Charlotte, Amber, Leanne, Whitney, there you go. We've got tendon. Yeah, don't let them throw you off. Remember, don't read the question. Go straight to your section, right? What have we got going on? 282s. Everything's going to be probably under the same header, huh? I bet they're all going to be under the same thing. 282. We're going to be all under bins. Ooh, look, I got my muscles and tendons. Got them all listed there. 28296. Yeah, they're all going to be under the same header. So we're doing repair, revision, and reconstruction on the toes, and that's going to be on page 200. Well, in this book, I don't know what version of the book I got open. I think this is 2024. So in the 2025, no, this is 2025. This is good. Okay. 2025. Which one of these are we doing? Some of them are out of sequence. And then 99. Where's your mama codes? Make sure you're under the right code. How do we code these codes if we are doing, you know, unilateral, bilateral? What if it's on one foot but done twice? What if it's done bilaterally on both feet? How do you code these codes? Just things to think about, but this particular question, we're on the right. Every answer has the right on it, so we don't have to worry about that. We just need to know, are we a 91, which is with an implant? 92 is a correction. 96 is distal. 99 is double. What did we do? We did double. So we know our answer is B. Be sure to mark those differences. Distal, 92 is proximal, 96 is distal, 99 is double. Now, don't be panicking. I told you guys we were going to be doing some difficult ones. This one's a case. I think it's 4 pages long, but we're not going to worry about that, right? We're going to look at the available answers first. I can see that every single answer starts off with a unique code. So I could really not care less about all this crap that's coming back here on the ends, right? If I can find my first correct answer, then I don't have to worry about everything else. Let's go see what our differences are. 22800 is our first one. I think they're all under the same header. They all look super close. What's our differences between these? Our OO, which is B, is posterior with 6. O2 is also posterior with 7. Are we posterior? We can look through our exam question. There are 4 pages, but the header did tell us, right? We probably ought to verify, but in the note somewhere, and it does say posterior again here, so that's kind of nice to see it, because sometimes the headers are a little wrong. You never know until you go into the note, but everything does point to posterior. So if you look at the 08, C and D 12, those two are both anterior, right? Anterior, and then these two are posterior. In my notes, let's see, where am I at for this code set? I'm sure I didn't do them for 2025 because I did them in 2024 and the codes haven't changed. And this took me 4 months to do because it was a lot. Because there's a lot in the musculoskeletal system. But the only difference between A and B and C and D is those differences. I just color code them. Anterior is always green, posterior is always blue. I know right away if I have 2 answers underneath this in that group and then 2 answers in that group, the first thing I look in my exam question is to find out if I'm anterior or posterior. I find that eliminates 2 answers right away. Makes the question a whole lot easier. Then I just need to count how many vertebrae. That's all. That's it. It's not as scary as you think with all those 4, 5, 6 million pages. Just take it one step at a time. Which answer do you think is correct? Do we have 6 or less, or do we have more than 6 vertebrae segments? And I'll let you guys look at the question longer if you want to, but that's the only thing that you need to know. Don't go reading everything else because there's no need. If it's not the differences between the codes, then you don't need to know it. How many vertebrae segments did we do? More than 6 or less than 6? We cannot be 12, which is D, because we are not anterior. We are only posterior. Anterior is 08 and 12. We cannot be these 2 codes. Because we are posterior on everything we did. Okay, it's all you needed to do was to find out if you were anterior or posterior. So your answers can only be A or B. And these code differences are just based off of segments. How many segments did we have? 6 or less, or more than 6? Indeed, we are A. Don't think that you got to go through that and look at all that mess. Just take it one code at a time. Bronchial scopes. Where are those located? We're talking respiratory, right? So where would your bronchial scopes be if we move over to respiratory, right? We're not going to be in the nose area. We won't be in accessory sinuses. Larynx, throat, trachea, bronchial, bronch. So our guidelines, or anything right here with our endoscopes, you see the little star right there? There's where our guidelines will start at the 31615. That page number is 224. Keeps you from looking all over the place. If you think about your body part and then what procedure, then you can find out what's included in them. 224. What's included in your bronchial scopes, right? Might be a handy area to look up stuff. That's what I'm using, Val. It's in a 2024 book. This is 2024. I guarantee you it says anterior and posterior. That's where I've got my notes from. Are you at the correct codes? Are you at 22800 after orthodesis, right? The second word is posterior for 22800. And the second word for 22808 is anterior. I'm using the same book you are. Promise it's there. That's because 22812 is a child code. You have to know that 12 is bundled with its mama. Its mama is anterior. Everything inside the mama code is inside the child codes. They tell you that in the beginning of your CPT book. If you look at the very beginning of the instructions on how to use your book, it describes how and why they group codes together like that. So if you look right here at the instructions for use of the CPT book, the way they format the codes and the indentions with the mama and a child code where they're indented over, and that the child code takes on the properties of the mama up until the semicolon, that's described up here in your guidelines for the instructions of how to use. So when I say that the 12 is anterior, I know that because I have her grouped with her mama code, who's anterior, right? So is 10. 10 is anterior also. Just like the 04 is posterior. Just like the 02 is posterior. That's why we group mamas and child codes together, so that you know that everything that's inside mama goes with her children. They're all posterior. These are all anterior. That's why we group them. All right, back to our next question. It takes practice. Practice, practice, practice. Oh, you gotta go feed your husband. I'm gonna be starving by the time this is over with. It's only 4:10 here. You'll have the replay for 90 days. You guys can come back and rewatch these. And I'm sorry they're so difficult today, but you know, I didn't want to just give a bunch of easy questions. I really wanted to see if I could teach you guys some things, but I'm supposed to be doing this in the same pace as the exam. As long as you get the knowledge. All right. And then you can replay this and turn me off and just pause the screen, hit play, give yourself 120 seconds and do the questions the right way, right? All right. Everybody got the answer to this one? How do we do scopes? Do we use our 51 modifier? Can we do it? They're starving. Days like today, I just order pizza and have it arrive and then they feed themselves. Yeah. Although I know it's difficult sometimes to even get pizza, you know. Times are tough. It's better to make a big old pot of spaghetti and let it last for 3 days, like my parents used to do. We'd eat that stuff second and third night on loaf of bread toast, you know, just put the spaghetti inside the sandwich bread and eat it for leftovers. Because we were done running out of garlic bread by that time. This one is B, yes. There's your answer. VATS. Where are we going for the answer on this one? I wonder if they're all under the same header. 3248. That's under excision and resection. The last code in that section. But we're looking for an 80, not an 08. I done got dyslexic with the answers. All right, 324. 80 would be under removal. All right, and then 32505 would be there also. 326. 326 is going to be under VATS, right? 32663 and 32663, answers C and D. So answers A and B are under removal, but answers C and D are under your header of VATS. See how this is pretty handy? If you just use this in the front of your book to distinguish which answers it could be, right away, kind of handy. You know that your answers have to be C or D. Then it also tells us what page number they're on, and so we're not searching the entire book or the section looking for the codes. We know we have to go to 231. So I can go there, and I'm only looking at C and D, right? Our code is the 3 Where is that one? 266, somewhere around there. 2663, which is right here. It's a child code. We got to go look back at Mama. Where's Mama? Mama's way on up here. She's a 50. She has a scope. She's surgical. And the 6'3" is a lobectomy, single lobe. Do we need to do that by itself, or do we need to add on the 66, which is the wedge resection? Did we do both procedures? Which is a mass, a nodule. Did we remove a lobe? Did we remove a mass? Or did we do both? Which answer would be correct? Would you add that code and that code together without a modifier? They're both children codes under the same Mama code. That's another thing that will help you out also, if you know how to code these. Is it more likely that your answer is one code as far as CPT codes go versus two? Do I do these workshops every day or every other day? Lord, I do these once a month. I haven't slept in 2 days because I've been preparing these questions. This takes a lot of prep work. Like, I was up all night long making sure these questions were posted, formatted in a Word document correctly for you guys, so you could see the question on one page, answer on the other page. It's not easy to get it all formatted into Word properly. Yeah, I only do them once a month. They take a lot out of me. Plus, I have to go find questions that I have not presented before, and I've been doing this almost 6 years now with workshops. I don't want people paying for questions and workshops with me who've been with me for several years, like Go-Kart, just to see the same questions presented that they've already paid for to see in a workshop over and over again. I'm not, So 6 years, I'm trying to, so anyway, no. I wish I could do them every day. This one is just D by itself. I ain't that good. Plus, I'm retired. I'm old. I don't work anymore. So I just do these to help you guys out. All right. Another case, right? Don't freak and don't be looking at all the different answers. We can tell right away. My strategy is that I have 2 answers with OOO and 2 answers that have O10. I'm going to go look at those headers and see what my differences are between those two, and then only look in my question to see what did I do. So what am I doing? 390? Are we in cardiovascular? Or are we still in? We're in cardiovascular. Oh, Lord. All right, take that out. 390. See how looking for the codes takes forever? It's nicer to look in the alphabetical index thingy that's in the front of the chapter. All right, 39000 versus the 10. What's my differences between these codes? If I don't give you the answer, here are my notes. What's the one-word differences that I would look for in the exam question to see which one we did, right? One of them's cervical approach, and one of them is thoracic approach. I have a color code for both of those. I know that that is the one-word difference that I will look in my exam question for to see which approach I did. with this one page right here, this case is, I don't know how many pages long. I can't tell. Okay, so it is 2 pages long. But this first page tells you the route in without saying cervical and without saying thoracic. So you have to find AKA terms that mean something different. What is our route? Are we keeping the OOO or the 010? Very good, Amber. You're awesome. Yep. That took me like a few minutes to figure out last night. I was like, where's my route? Where's my route? Oh, throat. We're cervical, dummy. But it was like 2 in the morning, so. But yeah, very good. So you know you can eliminate the transthoracic answers right away. But you can't draw on the exam like I am, so you have to learn how to do this with your imagination, right? You are imagining eliminating those. You're only concentrating on whether your answer is A or C. Would we use a 59 modifier or a 51 modifier for these codes that they're adding on in this section? How do you know the differences? 51 is like multiple procedures, and then 59 is distinct different procedure. 316, I mean, I don't know if it's very helpful to go look at those codes, but the modifier difference might be helpful too. If we're moving from cardiovascular section to respiratory section, hint, hint, it might tell you whether you're doing a 59 or a 51, but 316, 22 and 24, are they add-on codes? What kind of codes are they? Can't be add-ons if they're both got modifiers on them, right? 316, 22 and a 24. So one of them's mama, she's a scope, and one of them is a lavage, right? Here's the second page to this question in case you need it. If the modifier thing is too hard, you don't know if it's 51 or 59, and you just want to see, did you do a diagnostic or did you do the lavage thing in your bronchioscope? Copious amounts of secretions. Ugh. Yuck. What do you guys think? C's and A's. Amber, did you notice if you look at 22, look inside the CPT code descriptor with cell washing. Basically, same thing as a lavage, right? But, you know, that's why that separate procedure thing is in that descriptor, because what's done here is in the same, it's the same thing in all the codes in this area. So washings and biopsies are super confusing, super confusing. The other thing is, remember, AAPC is always seeing if you are an overcoder. The number one goal when they wrote these questions was to see if they could push you to build something that's more expensive. 24 is a higher number than 22. That means it's more difficult and it's usually paid at a higher rate. So, knowing that they write the questions trying to push you to build something that's higher, noticing that this has lavage in it and this one has washing in it, what's the safer bet to pick for a correct answer for your exam? Yep, it is confusing. The other thing is, these codes are not distinctly different, right? Both of these are basically, I don't know, they just are both endotracheal, they're both going down, they're both more similar but multiple procedures kind of like thing, not a distinct separate procedure, you know. So that 51 modifier would be better than the 59. You only use 59 if all other modifiers would not fit in that situation. It's like a generic thing, like nothing else will fit here. We didn't do multiple procedures. I don't know. Like, it would be different. It would be, if multiple goes there, then great. If that kind of helps. They do have some writing here in their explanation. I'm not quite sure I'm really happy with it, but they said 59 is not necessary because the procedure is separate, because the procedures are separate from one another. They are performed by different approaches in different areas. 51 is used to indicate that more than one procedure was performed during the same session. I don't know if I like that description, but main thing is don't pick a higher code for sure. Okay. Don't let this one scare you. All of the first codes are different. What do you guys think is the answer? A fast tip on this one: instead of running to each code individually and looking at the descriptors and driving yourself crazy, y'all know this page that's in page 248 and 249? This sucker is telling you the answers, right? And even the answers that are on our exam question would have to be here as a possible scenario to be able to be correct. So the only places that they have 3 codes listed are down here at the very bottom. They've got 3 codes down here, right? 3322522829. Then they've got 33225 or just it's one or the other, so it's only 2 codes. They have 3 codes listed right here. They have 3 codes listed down here. They have 3 codes listed here, just 2 here, and just 2, well, maybe 4 here. 4 here. Yeah. And this would be 3. But anyway, depending on whether you're putting in pacemakers or defibrillators, right, they're separated, right? So, which answer can you find on this chart? Because 3 of them over there you can't find because they're not on this chart. There is one that's on this chart. I find it a lot easier than going all around, figuring out if you did 1 lead, 2 leads, just a battery replacement, all this stuff. So there's not very many places you can look for 3 codes. In fact, the only one that has 3 on this one is the bottom line on this page and the top line on this page. Everything else is just 2 codes. So if it's not the 33272, then the only one that's got 3 in one possible answer would be over here. So which answer has either 33233, 34, or 35? That could be the only one that's going to have 3 codes. Does that make any sense? Yeah, it's only C. Good night, Janelle. See you later. Sorella says it's on page 242 and 243 in her 2024 book. Yeah, it's super confusing, but once you practice using this chart, if your question has 3 codes for pacemaker crap, you know you have to be able to find your answer under pacemaker, and it has to be here. And the only answer with 3 codes is that bottom line, and it has to start with a 233, a 234, or a 235. Has to. And we only got one answer that does that. 40 isn't even an option on the second side, but that's a defibrillator, but you're doing a pacemaker. And even pacemaker on the second side is just 2 codes, because that's an OR. Anyway, your answer has to be on this page if it's going to be correct for any of the pacemakers or implantable defibrillators. Yep, but C is your answer. Just trying to show you guys an alternate way instead of going to the CPT codes and looking up each individual one and then trying to remember about modifiers or whatever else. It gets confusing. So here's yet another one. This is all in one page too. Would these codes, if you combine them, need a 59 or a 51? That might be helpful. Or no codes at all. What is this 36245 code? What is that? It just cuts down some time looking at that chart and only finding the available answer that is listed on that chart. Once you practice it enough, it will cut some time down. All right, 36245. These are all pink highlighted. They are definitely going to be on your exam. 362. Three 6245 is a mama code. If I did anything, can I do this code down twice? If I needed to, do I use a 51 or a 59 modifier? Or is what I done already included all in one code? How would I find out? I would find it out from Appendix L, and I would have to see that our catheter placement in the arterial system was in two first order arteries, right? So if we go to Appendix L, lovely Appendix L, we are looking for what? It says the catheter is manipulated into the superior mesenteric artery and into the inferior mesenteric artery. If that is a branch and one of them is in second or third order, then it's just one code. If both of those are under first order, then we get to code it twice, right? So we'll look down our first order. We're just innominate and coronary. We keep going down and we got subclavian, axillary, bronchial, celiac, all that kind of stuff. Here's our mesenteric. Here's our first one. We've got one that is superior mesenteric, right? And then we have inferior mesenteric all the way down. There is an acronym, like little table over here on the previous page that tells you, way over here, what the little acronyms mean for INF or SUP. So be sure and stop by and see what all that is. But you can see how our superior mesenteric goes to its own box, where our inferior mesenteric goes to its own box. It has its own branch. So that means if we advanced catheters into both, then that's a different catheter for each because it's got its own branch that they go into. I'm not going from this mesenteric into that mesenteric all with the same catheter and making it through their branches, right? They each have their own branch. So that lets me know that my first code does have to be repeated. So back to our question, how do I repeat it? Do I do it with the 59 or do I do it with the 51? What do you guys think? Hey, Mayfield, no worries. Should be listening in the car. 51, I think. If you look for patterns during the CPC exam too, you'll notice that we've got the 45 down in 3 available answers. 2 of those available answers have the 59 modifier. The only difference between those answers is whether we add the 26 modifier to our radiology or not, right? So I like looking for patterns over our 51. It's only listed down once. It does have the radiology with the 26 modifiers, which is nice. These 2 codes can be repeated because you use the 51 modifier if they're different procedures. This is the same exact procedure. That's where that distinct comes in with our 59. There's no other modifier that I could use. The 51 would be like, I did multiple procedures, they're different, but I did them both on the same patient, right? If I did the same procedure twice on a patient, it's distinct. I did that procedure twice on the same patient. So that's why we're 59. So if you're going to repeat this code twice, you're doing it with 59. Like our previous questions when we had 2 codes, one from cardiovascular and one from the respiratory, that's why we used the 51, because there were 2 different procedures but done on the same patient. That's why it's multiple procedures, okay? Same procedure, same code, on the same patient, same day, 59, okay? Now we just need to know whether we're going to add our 26 modifier to radiology or not. Was our surgeon acting like a radiologist today? Did that doctor call in a tech to do the aortogram, or did the doctor doing this catheter placement also do and look at the films while doing the procedure? Do they get paid to be their own radiologist today? That's why you would add the 26. I hope this is helpful. Yep, it is B. So you got lots of stuff you can pause at and read later, but hopefully my explanation helps out a whole bunch, right? Hopefully it's a little easier, but pretty cool. I hope the explanation of Appendix L was helpful. Knowing that both of those were in the first, yeah, is super helpful. All right. Do this one. I'll try not to talk. What do you guys think is the answer for this one? We got about 1 minute in. I'll give you another minute. This one is super easy. That one was hard? Yeah, that one was. If you've never seen it before or explained it, yeah, it's pretty hard. But this one is pretty easy. Remember when we started this workshop, I told you guys you're only responsible for the differences between the answers. What if A is your correct answer? What will you see in your exam question? You will see you started 1, 2, 3, 4 catheters, right? If B is your answer, you did 1, 2, 3. If C is your answer, you did 2. If D is your answer, you did 3. How many did you do? 1, 2, 3. So you know you can get rid of C and A. Are they all first? Is the right and left renal artery first, along with the S superior mesenteric artery, right? SMA, you got to know your acronyms. Or is one of your 3 or something, 2 of your 3? So 2 of your 3 would have to be a second order for this one to be correct. All of these in B are main first order, where you only have 1 main here and 2 secondaries. So go look at Appendix L, see if renal arteries and superior mesenteric artery are all labeled at the top under first. If they are, then you know your answer is. If 2 of your arteries are in the box that superior mesenteric artery goes into for a branch, then you know D is your answer. If D is your answer, then your superior mesenteric has to go into your right and left renal arteries. Is that what happens? Because they have to be under the second, which is at the top, right? Second. The superior mesenteric only goes into the pancreal, duodenal, colic, and jejunal. That's it. Your renal, right and left, right, is right here in the main. Be a way to see it in your kidney one too. But this was just B. They're all mains. Yep. How many lobes does your liver have? You gotta love it. Your anatomy will be scattered out in between. usually right before you go, like if we're leaving the cardiovascular system and going into the digestive or whatever, then that's where your anatomy, a couple of questions will show up. You have lobes in your lungs, livers, and kidneys. They may ask you how many. Yep. Good job. We got 4 in our liver. We have 4 lobes, not 5. 5 are in our lungs. All right. What do you guys think is the answer for this one? Four, 3. So they're all separated by different types of surgeries. What did we do? Which is handy. That's under excision. Answer A is. Answer B is under scope. Answer C and D good Lord, C and D are under different body parts. Under abdomen, all that other stuff over here under scope, but it's abdomen, where here our answer B is under intestines. Are we under intestines or are we under abdomen, peritoneum, and this O word? C and D have that body part in them, and then B has intestines. So does A. Basically, they're just wanting to know if right before the codes, do you know that a surgical laparoscope always includes a diagnostic laparoscope, but also here's your scope, your peri, a lot of times they like to ask questions just about definitions. This isn't about a code or a particular descriptor, but do you know what's all included in a lot of these things? Which they'll describe, like the bariatric surgery, what it involves, the stomach, the duodenum, the jejunum, and the ileum. A lot of those can be just found at the headers. There's another one where the laparoscope includes your diagnostic. This one is B. Don't let it scare you. Take it one thing at a time. All your codes in the front are different. But I also know that my medicine codes in the back are divided into two little categories. Like, did I have somebody else assisting me to administer the twilight medicine, or did I do it myself? Knowing those differences would put you in different buckets of the 52 versus the 56. Would get you down to just two answers right away. There's the medication. Do we have 2 pages on this? I can't remember. I think so. Yeah. Total time, 30 minutes, so that's 2 15 minutes. The patient was observed by an RN, but who gave the medicine? That's all it needs. Sedation was performed by me. That means the surgeon did it. Just because the nurse stands by doesn't mean anything. We learned that the hard way in Alive recently. So, perfect. We would only keep the 52s. We would get rid of the 56s. So, we're either a 42 or a 46. Probably the 42. Let's go look. What's that? 432, 42, 432. 42 versus a 46. Ooh, these codes are on the exam. I got them pink highlighted. So, what's our differences? 46 is percutaneous, and then 42 is endoscopic. Ultrasound guided? We didn't see any ultrasound, did we? Nope, percutaneous. Ooh, I know where we're at. Where are we at? Which answer? You see how I only look up my differences? This one includes ultrasound, and this one includes percutaneous. And that's without notes. That's just looking at the different codes. Percutaneous versus ultrasound. That's it. Indeed, we are A. Yep. If the doctor gives the sedative themselves, then we stay in the 52s. The nurse has to give the medication to get counted. If the nurse is just supervising, monitoring, doesn't count. All right. You know, vasectomies, circumcisions, and penile implants will always be on the exam. These have modifiers. Ooh. So, if you know your meanings of your modifiers for this type of procedure, then you could probably pick out your answer because the code's the same. It doesn't really matter about the code. Would we add it or not? What do you guys think is the answer? Remember, we're not doing a circumcision on a baby. We're doing an adult vasectomy. So don't get confused. If you look at your description, it says it's unilateral or bilateral. We would not do just one side or the other, for sure. So we would never, ever, ever use the RT or LT to this. So we're stopping sperm from leaving the testes. And you would do both sides or it's not going to work, right? We would never stop a procedure, or delay it or whatever any of those things are. Just because a circumcision has the 52 modifier with it doesn't mean the vasectomies do. We didn't reduce services. We wouldn't discontinue services in this area. These are just here because you guys have probably practiced with the circumcisions, and if it was done without a block or something, you have to use that 52. This ain't got nothing to do with none of that. So we did a procedure and we just bill our procedure, right? So C is our answer. Don't let them confuse you. Here you go. Now you can do your circumcision. Now you can worry about whether you're going to have that modifier or not. This sucker that's always on the exam. I'm just confusing y'all so much today. Our thing says, report with 52 modifier when performed without a dorsal, penile, or ring block. What did we use? We did use a ring block. So we do not use the 52 modifier. So A would have been our answer. Please be careful and learn about that little paragraph right there. Super helpful. It's kind of difficult because of the verbiage. It's like, use it when you don't do it, but when you do it, you don't use it. It's confusing. I know it is. But it takes practice. All right. If we stopped a procedure due to circumstances that threat the life of the patient, what modifier do we use? I knew you would. Andrew passed his exam. I was like, I knew you would. I had no qualms. I knew he was going to pass. I'm trying to... Alright. I did it. No, that's not going to be helpful. Congrats to Andrew. Yep. 53. Everybody got 53? Don't forget to put in chat, what do you guys think is the answer? When all the components for 54405 are not met, what modifier do we use? They make it so difficult. You have to open it up in the app to get to chat. What a pain. You can't just open it up on the desktop on your cell phone. Alright. I'm just sending out 5 memberships to whoever's still left in chat. So YouTube will pick a winner. This one is a 52. What do you guys think is the answer for this one? It looks like Virginia, Melissa, Mock 4, Emily, and Beth all won YouTube memberships. You guys get access to all of my book prep videos, old workshops, and podcast for free for 30 days. This question seems to be divided up into 2 buckets in radiology, which might be an easier and faster strategy to run to. If you go to just the radiology, the 2 different codes, and see what the difference is. 744, 20 and 25, 744. And 25. One is retrograde, the other is antegrade. Are we retrograde or antegrade? We're retrograde. So that gets you down to just 2 different answers for your CPT code, right? Then did you do your 2224 or 234? We've got our indications, our procedure. Ooh, we did cystoscope rigid. have a urethra step retrograde. Yep, yep, yep. They have a description here of what's included in each. And if you know this paragraph, then you know the answer to the question. Because they're just asking if you know what's included in all of these, right? Do we use electricity or 2, 3, 4? Also uses electricity. Oh, it's the size. Are we small bladder tumors or are we minor? Less than 0.5. Ooh, how big was our tumors? Nothing. They don't even mention anything. So if they don't do any sizes, yeah. You're welcome. This one. Very little, nothing. We did D. COVID and pregnancy, usually a question on the exam. It was a late entry. I should have had this up with the ICD-10 codes, but somebody reported it on their exam this week, so I wanted to find a question for you guys. So I was already in the middle of the exam, so I threw this one in real quick when I remembered it. You're welcome, Mary. What do you guys think for our pregnancy, right? We still got 32 of you guys on. And what's pregnant patient? Do we need to do symptoms, pregnancy, and COVID? Do we do pregnancy and COVID? Do we do COVID and then pregnancy and then manifestations? We're going to do our OB and then COVID and then any other manifestations if we need it. Now, what if we see a patient for burns and they're pregnant in the OR? What will be our ending diagnosis back here? What are you guys looking for? What's the code that I told you guys is like a cheat code? If you happen to be seeing and you're not their OB/GYN doctor and you're in the ER or something, right? Different specialty, and you're seeing a pregnant patient for something unrelated, and you want to say, oh, by the way, they're pregnant, because it does make it does matter. Like, we can't give her a bunch of narcotics or a lot of things that would affect the 12-weeker, right? So it is a consideration. Do we diagnose her with pregnancy or a status code? What do we do? Good job, go-kart. Yep, D is your answer. Always look for that Z33. That one's handy dandy. If you know that ending code, oh, by the way, they're pregnant, that's always on there. Would this ending code require a 59 modifier or not? Would these codes require a 51 or a 59? Sometimes that is super handy dandy to know. What kind of code is 56605? Five 56605 is an excision, and it's a parent code. Go away! I'm doing a workshop, baby. You can wait 5 minutes. Please don't stick a knife in my door. My child's been digging at my bedroom door for 5 minutes with a knife trying to get in. Like, dude, I locked it for a reason. Unless the house is burning down, go away. And then I'm gonna wait for the smoke alarms to go off. How would we attach a biopsy to these codes? What do you guys think? If we did hysterectomy, anterior, repair, right? And a biopsy, what modifiers would you need to see, right? Or not see? That can help you get down to correct codes. Also looking for similarities. And knowing that this is not an add-on code, right? What do you do if you have an additional procedure, right? It's not an add-on code. It's a separate, distinct procedure, right? Because it's a biopsy on a totally different part that's not getting repaired, and then that's not part of the hysterectomy. So just knowing that it would require a modifier for that one code tells you right away what the answer would be, right? This would be a multiple procedure because this is attached to the cervix, right? So it's multiple procedures, not distinct. The only one that's distinct is this one because it's not attached, technically, to what was removed, right? Because there's a different area, right? Anyway, you can dive yourself into all this mess and drive yourself crazy with these cases, going all into the procedure. But if you know a little bit about the codes and what it's like to have a mama code, right, that you need and have to code because it's there in every available answer, that will make picking out the answers on the exam a lot easier. You definitely, on that 05, had to have a modifier with it because it's not an add-on code. All right? Again, with these, if I'm adding this code to that one, which is in every single answer, what is that 622 code? I think we've already looked at one of them like that today. 6222 reminds me of another one we looked at today. 622 2222. $62225. That's a mama code. What is this code compared to that code? Are they distinct separate procedures or just an additional code, right? 62230, which is right below it. One of them's replacing, one of them's replacing. One of them's doing a shunt and one of them's replacing a catheter. If we're coding both those together, what's our proper modifier? Are they distinct or are they related? These will make a big difference if you start looking at your available answers on the CPC exam. They do this on most of their questions. They'll have little differences like this. Which ones are just coded double or times or added the 59 or added the 51. Yep. Or what's included into one code. Does replacing a shunt also include replacing the catheter? You'd think it would, right? But I don't know. Apparently not. You do have to code both separately. I guess you can just do a shunt that doesn't have a catheter also, I guess. But they drain right into they got to drain somewhere. It's kind of weird. But E&M, my guys. Would we use the 24 modifier, 55, or 79, or not bill the service at all? So what are these modifiers? 55? Where is that? Post-operative management only. Okay. 79. Unrelated. What do we got going on? What would we do? What do you guys think? Type it in chat. You had it right the first time. Don't second guess yourself. Eek. Jenny got it right. Good job. 24 modifier. Don't forget about that one. If they're going to use a post-op modifier on the exam, it's usually 24 or 74. One of the anesthesia stop ones. They love those two codes. All right, what about this one? What do you guys think? Don't give up. $57. Good job. Perfect. All right. Good job. Sometimes they might ask questions on the certification exam about a particular code. They want to know if you know the full description of like children codes, or what the code includes. So let's go to 692. 692. When we're removing cerumen that's impacted, anatomy-wise, what type of ear function is blocked by that impacted earwax? And they throw you the most random stuff. What needs to flow and what is listed in 3 of your answers, right? Look for your similarities. Yep. We have our air conduction, right? Yep. Oh, 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 oh. I'm hitting wrong things here. Hold on. All right. If we are doing lab, where are we at? If we are doing 8, where are we at? 8. Our lab have 8. 10. I guess technically the answers are all in the same question. I mean, one of them's different, but more probably is what about which modifier, right? 8100. They're always pushed out of whack. So all the other codes are all up in their freaking way. So just finding the codes is such a pain. These codes definitely on your exam. Would we need the 26 modifier and a QW, which is in your hit picks book, if you needed to know where the modifier is or not? Travis is needing some shampoo. I'll be right. I'm gonna give him some shampoo while y'all are looking up your modifier, I guess. Let's see. I think I got some in here. Which answer do you think is correct for this one? Indeed, Jenny. You guys are great. The routine drug, urinalysis does not require a CLIA waiver, so you don't need that modifier. Only things that need to be like calibrated or require some sort of training to do need that CLIA waiver. This type of question right here will definitely be on the exam. Knowing how to code your organ or disease-oriented panels is always an area that's on the exam. What do you guys think is the answer for this one? Yep. It takes a lot of practice, Cynthia, to find those, because those are way pushed out of the wrong area where they should be. They're after the 8.3 codes, even though they're 8.1 codes, but they got pushed out of the way because a bunch of out-of-code sequences got put in the way. What do you think about these codes? How are we going to order or bill for the physician orders for all these lab tests? Indeed, the two codes. Good job. What about this one? This one's probably going to be a couple of pages. Let's see. Yeah, 3 pages. So, yep, we need to see how many specimens we have. So that we know which answer could be correct. If it's answer A, it means one thing, right? Answer B means a different thing. 88, 313. So just counting the answers and seeing how many stuff was ordered and done is usually my strategy here. 33, 13. What is 13? 13 is stains. Okay. So I did 1 biopsy and 1 stain. And then I would have done 1 biopsy and 2 stains. 1 biopsy and 3 stains. And then a 51 modifier for that kind of code. I don't know. Alright, let me look through my question. How many stains did we have? And then back up to our available answers. There's a parenthetical down here that says report 1 unit of 88313 for each stain on each block, specimen, or smear. What does that mean? So if you have 1 specimen, then you code your staining once, right? So we know our answer is how many specimens did we have that needed to be stained? Let's see, we got clinical indicator received labeled Smith liver, 4 biopsies, fragments, Smith set A, liver, core biopsy, Y'all like the 51 modifier? Oh, let's see. What do we got? Let's see. We have 1 cassette specimen, core biopsy, and then 4 the stains. The thing right down here says report 1 unit of 88313 for each special stain on each surgical block. So each stain, how many stains did we do? We did an iron stain, we did a PSA stain, and a stellosis whatever stain. So we did 3 different stains or whatever. So that's why we times it by 3. Sometimes it takes reading those stupid codes and the parentheticals multiple times to get it, you know? It's crazy. But those are done by each stain. Not by each specimen. And not by each, how many containers. Vaccine. So I don't think I got that one either. Because that was C. All right. Vaccines. And then we'll move on to some E&M. Almost done. I always like to throw in a vaccine just in case. Only got 25 of you guys left. 4 hours is a long time. All right. What do you guys think for our vaccine? Influenza, pneumonia. Our differences between our 904, 71, and 72. Those are usually the easier ones to look up. $72 is an each add-on code, so it cannot be the only administration code. So you know that B goes away. How many vaccines did you give? 71 is for 1. If you did an additional vaccine, you'd add on the 72. So we know D goes away. So it has to be A or C. Now it's just a difference between, just pick which one. Do you want to do the 906.58 or the 907.36? Which one? Or the 32 versus the 57? For depending on which type of influenza or pneumonia that you had. Be sure and type in chat what you guys think is the answer. Very difficult. Very difficult tonight, yep. These are like some of the worst, right? But if you know how to add codes together, your modifiers, I promise it will help with your CPC exam, because you can look at available answers and go, oh, we'd never add a 59 there. Those two codes are close together, right? They have to be distinct, separate sections or whatever, right? Same kind of codes in the same kind of section. This one's an A. This biofeedback training is usually always on the exam. "15 minutes. Would we add an additional 15 minutes down?" That's all this one's asking for. And if the physician only spent the 15 minutes, you know it's just the one code by itself. So don't let them confuse you, right? Super easy. That one's just done by time. That's all. So we got our E&M coming up for the rest of these codes. These are going to be just knowing whether you are, under what header, right? Are you subsequent, hospital visit? Each one of them comes with a different type of guideline, like our outpatient office visits versus our inpatient consultations versus subsequent hospital visits. They all have little quirks depending on which header you're under. So see what you guys can do with these. Gotta stand up a minute. Turn all that down. Fold the towels now. Are we an established patient, inpatient consultation, subsequent hospital visit? What are we doing? What are we doing today? I'm taking my exam on the 3rd, which is on Wednesday, Jenny. You were doing good. Best of luck, absolutely. Now remember, what happened yesterday? Surgery to remove cancer from the spinal cord. Don't you think your surgeon coming by to see you the very next day is part of your global, right? And non-billable? Just because a header is there does not mean you need to bill it, right? Don't forget about global days, right? You cut on somebody, they're still in the hospital. You got to make rounds on them the next day, right? It is included. All right, what about this one? I don't think anybody got that one either. Yeah, we'll be better prepared for the certification exam after seeing these. Promise. I know it's stressful to miss them today, but you won't miss them again. You'll remember, oh, Jen said no. Jen said this. Look for this. It'll be helpful. Don't feel defeated. These are like the ones that no one would get right the first time they see it. And that's why people stay in the 54, 64 range on the certification exam. If you know what you did wrong on the questions, then you don't miss them the second time you see them. So this is helpful. I don't mean to scare you. No, this is just the difficult crap that everybody gets wrong. And it's better you see them now than you see them in 4 days and get them wrong, right? Because you don't want to spend another $500 on 2 more exam attempts. Okay, what subcategory and category are we in for this evaluation and management? Yeah, it is exhausting. Yeah, and not passing. Yeah, I feel your pain. I'm just trying to help. I don't mean to make you feel like you don't know anything. I'd hate to show you an exam that you paid for today and you breeze through it and think that you're going to get everything just like this again on your certification exam, and then nothing I show you ended up being on your exam and it was super tough. Okay, Michelle, remember your 3 rights for a consultation. You have to have a request from another physician to see a patient. That request has to be done. And then there has to be a letter back to the doctor who requested saying what their recommendation was. So, did one doctor request this patient to be seen on some small section of their health care? If Miss Lisa decides to consult an orthopedist, what can that orthopedist bill when she self-referred herself to the doctor? If there was no request from another physician, then what does this orthopedist need to bill? I noticed, Jenny. My dad used to call me Jenny all the time, but he spelled it Jene like that. And then my grandmother used to spell Jennifer with 2 F's. and two N's. It's too funny. So this has to be just a new patient visit. Remember, if a doctor did not request the visit and then that patient got seen by the specialist and then that specialist wrote a letter back to the referring physician, then maybe you could do it. But, you know, even if the primary care physician requested the patient be seen by the specialist, that still doesn't mean a consult was done. That doctor has to not treat the patient and only give recommendations back to the primary care physician for how they should treat their patient. That's all a consultation is. They don't treat the patients. They just give advice. Now, if a doctor takes over care and starts treating the patient, that's still a new patient visit. So a consultation is only advice written out without treating. Okay, what about this one? And I think this one is 2 pages. If you don't have MDM in time, and all you have is this office visit, and you have a diagnosis, you have data, and you have risk, you got to have 2 of those 3 levels to match. What would you bill for this patient? A level 2, which is just a 212, or a level 3, a level 4, or a level 5. You're welcome. It is very confusing. Yeah. You'd think a referral is a consultation, right? A doctor refers you, but it's not. A referral is a take over the care of the patient, and that's just a new patient visit. It's stupid. A consultation is a request, a rendering, and a report back so that doctor can take the advice of that specialist and treat the patient with that advice. If overall healthcare wise, the primary care physician deems that's appropriate. Because that specialist is only looking at one tiny little piece of things. It's just a level 2, 3, 4, or 5. Are we straightforward, low, moderate, or high? Where do we put a fractured leg with x-rays ordered? Blah, blah, blah. And done. They did the x-rays. Yeah. One helpful tidbit for your certification exam: to know whether you are a level 4 or 5, right? If you look at page 10, look at your diagnoses right here. if there is an injury, like a broken leg, it has to pose a threat to life to be high. She's not about ready to die, so we know she's not a level 5. Here, if we look here for injury, is there any injury? There's one acute complicated injury. The rest of them aren't injuries. This doesn't seem too complicated because they just x-rayed it and sent her on her way, right? So you know you're not moderate either. There's not an injury under minimal, which is straightforward, which is the 2. So where would just the fractured leg go, really, right? It's an injury that requires observation or whatever, you know, supervision of care, right? Just an uncomplicated illness or injury, really. So you know you're a low with this patient. The x-ray that they took and looked at, they're going to bill CPT codes for it, so you cannot count that as data. And they didn't even write any prescriptions or anything, so risk is minimal. What about this one? I think we got 3 pages, so let's go to the bottom and see what was done. We got severe exasperation, so you know if you look at the diagnoses for anything, severe exasperation is under high, because over here we've got just with exasperation under moderate. So our problem list already starts out high with that word. What do? We gave some drugs. We did labs. Where are they admitted to? Are they ER or are they admit hospital? Where are we? They were admitted to the hospital 2 days ago. Oh, okay. And what are we doing today? Who are we billing for? Are we billing just for today? Recheck, increase. So are we subsequent? Maybe? Because it doesn't look like they're discharging them. Blood pressure's still high. Saw them for 20 minutes. Would we be admit or observation, a consultation, subsequent hospital visit, or a regular outpatient office visit? Admitted 2 days ago, seeing them since they were admitted. What do you guys think? Looks like they're gonna recheck labs tomorrow. There's your available answers. Yes, subsequent hospital. Yeah. What about this one? We'd probably have to get back some. Hey, Mayfield, good to see you. We were just finishing up with some E&M codes. I got 2 more questions, I think, after this, and that's it. It's hard to do those cases all on one page without the font getting so tiny for you guys. What do you guys think? If we are doing a screening on a Medicare patient, we are usually a HIPICS code. Be careful with this one. If a Medicare patient is here getting biopsies or polyps removed or something like that, and it's a diagnostic colonoscopy, will be in the CPT codes. But as long as we're screening, we'll be HIPICS. And yes, D is our answer. Okay. What do you guys think about this one? Are we new patient, established, consultations? we are A. Good job. I think everybody got that one. Yep. If the cardiologist is going to manage and treat the heart condition, then that's takeover care. Yep. It's not advice back to the PCP for them to take care of their own patient. It is takeover, which means new patient. Okay. Try this one. Don't forget to look at your critical care guidelines. If we did critical care less than 30 minutes, we cannot bill it as critical care time. The patient doesn't seem to be, I don't know. You know, it's like we're not the one who admitted them. They got transferred to ICU. So it's tricky. We're not inpatient admit, right? The ER doctor, they kind of give you a hint right there, can only bill for ER visit, right? So A is going to be our answer for that one. It almost seems like it's an admit, but transferred to ICU. Somebody else will take over care and do the admit to ICU, but that doctor will bill for their time for the 20 or so minutes, whatever it was, for doing the emergency room visit. So super crazy. No one ever gets the consultation. Everybody's new patient, especially if they self-refer. If they take over care, you know, it's still new patient, and nobody's in critical care unless they meet the requirement and exceed it, right? You've got to exceed the amount of time, so be careful. Stay with your first instinct. Yep, don't switch. Don't switch. Yep, always. Well, I hope this has been super, super helpful. I know it was super difficult, but don't feel defeated. I promise these were the worst of the worst. I didn't want it to be easy for you guys. I wanted to show you what everybody's getting wrong, what hard questions that people are getting wrong. And if you want to go from the 60s to over the 70s, this is what you got to watch out for. Look for those differences between adding codes, your differences between anterior, posterior, antegrade versus retrograde. Your mama and children codes. Look for those mama codes. Utilize the indexes in the front of each chapter. Figure out if answers A and B, you know, are under an excision, but only under that body part. But C and D are under an excision, but under that body part. This will help you to look for what is different between two groups of answers, and then it'll tell you what page number to go to, so you're not searching the whole chapter looking for something. So utilize this. These are handy dandy. If your answers are divided up between incisions, destructions, and excisions, even if they're all under the same body part, this is still helpful if they're divided up between different surgeries, and it can still tell you what page number to go to find the correct answer. Once you decide you're under that body part and you are really underneath that one procedure, then a lot of times you can just pick the answer and move on to your next question. You don't even have to go to the CPT codes. But if you have two answers that are both repairs, then it'll tell you what page number to go to, and then you can go see what your differences are really quickly. And usually it's the route in the body. Did I go percutaneously? Am I open procedure, or did I scope them? Did I do an incision? Did I go under the skin? Or did I go down the throat, right? Or whatever, scopes. And then, if I did a repair, did I do it on the anterior side or posterior side? Medial or lateral? That's it. That's the only differences between these surgeries and stuff, right? Did I add a manipulation? Did I not add a manipulation? Super helpful. Probably a couple of things to get down in your book for the business of medicine is MIPS and AMP. Go figure out what those programs are for and write the definitions in your book. That's helpful. And then be sure to figure out where your table is in your guidelines for adverse effects, poisonings, underdosing, and toxic effect. It will tell you which ones to code first. If it's a symptom first or a T code first. Okay? That will make a difference because that's on the exam. Okay? I hope this is helpful. I'll see you guys tomorrow night. We're going to do 2 hours free lesson on TikTok and YouTube. I've already got the links up, I'm sure. And if y'all need anything, just email me away, okay? Check up on chat one more time. Fingers crossed for everybody. Yeah, the replay is the same one. Yep. So the link that you used to get in today is the same link to replay it and watch it for 90 days. And then I'll turn it over to the people that have the membership, probably 9, 10, 11, somewhere after Thanksgiving. So got plenty of months. Probably won't be till Christmas, and I'll remember to go turn it on for the people that have the memberships. All right, guys. I hope this is helpful. If you did win the YouTube memberships today, then you can go to the YouTube tab, and on the YouTube tab, it's really cool. At the top, it's got my channel. Go, where's YouTube? Go there. Nope. If you go to my YouTube channel by clicking on my little name right there, up at the top right here, it's got videos, shorts, live, podcast. Keep scrolling over. Playlist. You can click on playlist, and then you can see all the different playlists. And of course, one of the good ones is the guidelines, but I've got me doing the notes for all the guidelines. So I've got ICD-10 book prep. I've got CPT book prep. All the old workshops, you have 45 of them in there. If you won the YouTube memberships today, that you can go back, and there's 3, 4 hour, 5 hour, 6 hour videos of nothing but practice questions, just like today, where we do them and see if you got the answers right. So you can turn me off, bring up the YouTube videos, and do those question by question and get the notes in your book. I do 2 a year for free, so even if you click on that, and you'll see a bunch of them that don't have member only, right? And there'll be some that are public, right? So the ones that are public are the ones that were done every Christmas and every April for my birthday. So there's 2 a year that are done for free, and everybody has access to those for the past 5 years. And then only the ones that are the paid, like you guys paid today to get in, are the ones that I release after 90 days to go into that membership. But if you won the membership, then you've got access to the ones that light up and say member only, member only. Anyway, I hope this is super helpful. I'll be around if you guys need me. But there is a ton of them there. And for $5 a month, the YouTube membership is really cool. You get access to a lot of stuff, for sure. All right, guys. I hope this was helpful, and I'll see you guys tomorrow night. Time to go eat some dinner, too. The AAPC will show it under scheduled exams. Oh, that's awesome. Thanks, Val. Can you repeat those tables one more time, please? Yeah. The tables are in your guidelines. It's the one for the toxic effects of medicines, which is on G27 in my book. It's table IC19E. It should be in everybody's guidelines, no matter what book, because this is not a table that AAPC wrote. It's one that comes with the guidelines. And it is about adverse effects, poisoning, underdosing, and toxic effects. Each one has a different way of doing the code set. Sometimes you do the symptoms first, and sometimes you do the T code first. And if you want to know the sequencing, it's right there. Super helpful for your exam. Yes, tomorrow, 4:30 Arizona time zone. It is 6:30 here now, so. All right, guys. I'll see you.